Hi, everybody. Welcome back to the CVSPD Flexible Endoscope Virtual Conference. What a day. It's been an amazing group of speakers that we have engaged with and have been able to really showcase their knowledge and hopefully help you, our audience, gain some valuable tools in order to bring them back to your departments and move forward in our industry a little bit. The event is hosted by Beyond Clean and sponsored by Agility and Northfield Medical. And as you all know, it's been a full day of exploring endoscope education and quality. So I am going to introduce Nancy Chobin. Nancy Chobin is the president and CEO of Sterile Processing University. She is a consultant on a mission to provide sterile processing departments with the skills and knowledge to be successful. Nancy has consulted to over 260 hospitals as well as many medical device manufacturers throughout her career. She is a well-known healthcare industry consultant dedicated to improving patient safety. Nancy is a renowned national and international speaker and has received many awards in the field of sterile processing. Nancy is going to tackle ethical issues in endoscopy processing. She's going to define and discuss how ethics, morals, and behavior impact endoscope reprocessing staff on a daily basis. Get ready to discover how ethical issues and staff behavior can impact both patient and employee safety. She'll be joined by Lindsay Brown, myself, and Adam at the end of her session to discuss additional on this end. So it is my pleasure to welcome Nancy Chobin. Nancy, welcome.
Thank you so much. I really appreciate this opportunity, both from Beyond Clean and all of the sponsors of this program. I've been doing a considerable amount of legal consulting of late, and this really has brought to my attention a number of ethical issues that we face on a daily basis, and no one really talks about it very much. You hear it, with doctors and lawyers and professions like that, but we don't hear about it too much in sterile processing or endoscopy processing. So I thought it was important to have this topic. So we had a full umbrella today of all the different things that we need to talk about. So there was an article when I was researching ethics in endoscopy processing by a gentleman called Stephen Coughlin. And he authored an article called Ethical Issues in Epidemiological Research and Public Health Practice. And he said that healthcare professionals may face ethical issues such as conflicts of interest, distortion of medical facts, exorbitant or inconsistent billing, poor privacy and security of patient records and information, and compliance with local, state, and federal health regulations. That's where we fit in. Because non-compliance with healthcare legislation related to ethics can directly result in harm to patients, healthcare employers should provide ethics training and policies for their workers. And I don't know if all of you get it, but I know before I retired, the last 3 years I was employed, we did have ethics training, which was mandatory. These courses and policies explain the ethical issues that healthcare workers might encounter, why they exist, and how to deal with them. The penalties for not following the guidelines set in these training courses and policies are sometimes severe. Workers could face suspension, fines, loss of their medical license if they have one, or lawsuits and jail time, depending on whether the worker violates employer or licensing body ethics policies or ethics legislation. And understand that most certification boards do have an ethics policy where your credential can be suspended or even revoked depending on the seriousness of the issue. So let's look at some definitions. Ethics is the discipline dealing with what is good and bad and with moral duty and obligation. Ethical actions are actions which conform to accepted and professional standards of conduct. But these ethical actions can be complicated by our individual beliefs, our knowledge base, and even our work ethic. Morals are of or relating to principles of right and wrong in behavior, and you should have a set of moral principles or values. Unethical behavior is professional conduct which fails to conform to moral standards or policies. And professional ethics is a principle of conduct governing an individual or group. So professional ethics is usually what is in the code from each of these organizations. What about ethics today? What we do and how we do it affects the lives of everyone in and out of our profession. No individual or group is untouched, and we need to reaffirm our moral obligation to do the right thing. Now, when you look at professional codes of ethics, many healthcare organizations have them. The American College of Healthcare Executives, the Dental Hygiene Practice, nursing. But where is the Endoscopy Processing Code of Ethics? We didn't have one in sterile processing either. So I had made one up a number of years ago, and I keep updating it, and I amended it to endoscopy processing. These are some of the things that I feel should be in our suggested code of ethics. Always act in the best interest of the dignity, reputation, and good standing of the GI endoscopy profession, applying professional judgment and acting responsibly in all matters related to patient care. Always act with courtesy and consideration to all those with whom you have to deal, including fellow professionals. You know, sometimes we come to work and we just don't feel like dealing with people, but when you're there, we have to work as a team. Always comply with regulations and professional standards with regard to safety and processing issues. And I can tell you that when it comes to litigation, this is one that could cause real problems for your facility, non-compliance with national standards or regulations. Communicate clearly and concisely. Remember that communication is a two-way process and that listening is critical to the process. I remember one time we had just started a case cart system, and the operating room, all of their supplies were in SPD. We pulled the cases for them, and it was like 10 o'clock in the morning, and the operating room calls and says, we need the mother-in-law retractor. And we're all looking at each other, what the heck is that? We moved everything. We didn't see anything labeled the mother-in-law retractor. So we're opening things. We thought somebody labeled something wrong, which is crazy because we didn't know what it was to begin with. I finally had to get up enough nerve to go to the operating room and ask the surgeon what he wanted. And he said, oh, it's the Cobra. And I said, well, why did they call it the mother-in-law retractor? He said, well, it's ugly and it looks like my mother-in-law. Now, that was fine and dandy that everybody in the operating room knew that. But in sterile processing, we didn't. And it caused a lot of problems. We lost a lot of time that day. Maintain documentation of all your training. I can tell you that many times when I ask for documentation of training, especially in endoscopy, it's very poorly documented, or there's very little documentation. I'll see something like, cleaning the scope, leak testing the scope, none of the steps in between. It does not give a full picture of the amount and quality of training that was given. Maintain your continuing education and certification by attending continuing education programs and retraining certificates for verification of program content and of your attendance. Now, things are changing very rapidly in healthcare today. I have trouble keeping up with it, and that's my full-time job. So we have to constantly make ourselves available like you're doing today. And I applaud all of you for taking the time out to attend this program because you need to know about the changes that are happening in your profession. Identify safety and/or risk management issues and report them immediately. That can be an employee issue as well as a patient issue. Never disclose confidential information about a patient, and that is a HIPAA regulation. Never disclose confidential information about happenings at the facility. There could be legal implications. There was an article that was written a number of months ago about two people in the supermarket, and they were saying, oh, did you hear what happened at XYZ hospital? Oh, yeah, they did this or that. And, here it is out in the public, and you cannot be assured of the accuracy of the information. And they say that the worst type of information given about a facility is usually word of mouth outside of the facility. So we have to be very careful about that. If you make a mistake, try to minimize it and own up to it so that corrective action can be taken. This one is very difficult. No one likes to admit they made a mistake. They're afraid they're going to lose their job. They're afraid they're going to be made fun of. But I can tell you, in my legal experience, the cover-up is sometimes worse than the crime. It takes a very big person to own up to a mistake. We're all human. We do make mistakes. And, you know, if it happens, at least if we find out about it right away, we can make the change and at least mitigate the damages. But we can't just allow it to go on. I tell this story all the time. It's about 10 years ago. I went to a large facility, and they had two automated endoscope reprocessors side by side. And when I went in, they had towels all along the top basin of the second AER. And I said, what do you have the towels there for? And they said, oh, well, we have a leak, and so we keep the towels there so the water doesn't go all over. And I said, well, are you testing the solution? Because if the water goes in there, the solution may become diluted. Oh, yes, we test it. Well, how often are you testing it? Well, every day. I said, well, it's supposed to be tested before each use. So did you test it yet this morning? No. Okay. So we tested it. Of course, it failed. I said, now I need to know what scopes you put in this AER yesterday. Well, we don't know. What do you mean you don't know? Well, we don't write down what scopes go in which AER. Well, how many patients did you see yesterday? 190. I almost fell over. I said, then we're going to have to notify risk management and infection prevention that all of the patients who had an endoscopy procedure yesterday are going to have to be notified that there was a potential that the scope was not properly disinfected. And the response I got was, do we really have to do that? Because this happened a year ago, and we all got written up. And I said, you know, if you don't do it, I will. This has to be reported. So we really have to take it on the chin. When we make a mistake, we have to own up to it. Seek total quality management for all stages of a process. And I know that's difficult. We're going to talk a little bit about that a little bit more. Report any instances of facility property damage or theft and don't participate in it. Treat coworkers with dignity and respect as you would like to be treated. Accept constructive criticism as part of your professional growth. Let me tell you, I've had my share all along. And it really does add to you. You learn from your mistakes. My mother always said it's never a mistake if you learn from something. And accept changes in work schedules when they are dictated by patient needs. That's why we're there. It's not McDonald's. You can't do it your way. We're there for the patient. Always strive for the highest standards of excellence and never assume. Make sure that all devices are processed as if they would be used on you or a family member. Practice competently. When in doubt, ask for advice from a qualified coworker and take responsibility for your work and make sure that it is completed on time and accurately. So what are some of the ethical issues that we face on a daily basis? And they might not all happen on the same day. We have the entitlement ethic, you know, be happy I showed up today. The work ethic, ethical issues with sales representatives, ethical issues with employees, ethical issues with patient safety, and ethical issues with employee safety. Let's talk about work ethic. We work in a diverse environment today. We have people from different cultures, and we all have to work together. But the differences in cultural beliefs or behaviors can sometimes create misunderstandings between the staff members. We should learn as much as possible about how cultural differences affect work practices and incorporate those differences into departmental functions without compromising the processing aspects. When we understand these differences, it can facilitate teamwork that is needed for a well-functioning endoscopy area or department. We have to remember, not everyone was trained the same way, not everyone came from the same background, and so we have to work together and learn what our differences are and make sure that we can all work together with those differences. Patient confidentiality. The endoscopy processing technician has access to confidential patient information through the GI endo or operating room schedule, computerized records, the issuing of equipment, and even patient charge systems. We know and understand that all patient information is highly confidential and should never be discussed with anyone at any time unless it is required for the direct care of the patient. All healthcare facilities must comply with the Health Insurance Portability and Accountability Act, known as HIPAA, which provides for the confidentiality and security of health information. And in addition, each facility should have procedures regarding the destruction of confidential records. Facility property. Stealing or damaging department or facility property is also an ethical issue. Now, well, what kind of facility property am I going to take? Well, I've had employees who were taking alcohol, peroxide, tissues, stuff that you could use at home. The hospital had to pay for it. Your center had to pay for it. That's stealing. And I explained to one employee one time, if security stopped you, you could have been arrested. Is it worth it for the small amount of things that you're taking? So we need to be aware of that, especially today where we're all faced with such tremendous increase in costs in healthcare. The equipment that is used in patient care is expensive and must be used as directed by the instructions. And I actually saw an employee one day pull a piece of electrical equipment out of the wall, but instead of pulling it out from the plug, they pulled it out from the cable, and of course the cable became disconnected from the plug and it was sparking all over the place. Abusive equipment is costly to the facility, especially if the abuse is not noticed before the equipment is needed. And, that goes across the board. I've had instruments and devices come back to me that were damaged, and I reported it. And as soon as it came in, I take a picture or go up to the room and talk to them about it. But sometimes when personnel witness such activity, they don't want to get involved. Ethically, however, the right thing to do is to report it, or it's going to keep happening. Sales representatives. Now, we all love our sales representatives. They do a lot for us. They're always there when we need them for training, if we run out of something. But understand that the end user, that's you, of any product or equipment, has the responsibility to ensure it is used and processed according to the most current written instructions for use, which we now call IFUs. The best way to get this information is from the company's home office, which should have the most current IFU available. Now, there are many companies that put them on their website, and they do keep them current, but I've been to some web pages where they are not current. And the same thing with sales reps. I've had IFUs that were outdated. Inaccurate or outdated IFUs can impact on patient safety. Always ask for information in writing and keep it on file. I always use the concept, trust but verify. I don't take anything verbally. It has to be in writing. Employee behavior. Sometimes employees feel that they don't want to get involved, so they do not report problems such as staff member leaving the workplace for several hours or not reporting for work at all but getting paid because he or she forgot to punch in or punch out. I've had this happen as well. This is a financial loss to the facility and needs to be reported. But in addition, it's unfair to the employees who do not exhibit unacceptable behavior. And they start to believe, you know what? I'm the fool because I'm coming in here all day and I'm doing my job, and these people are getting away with it. So everyone has to abide by the rules. Employee safety. Ethics also involves reporting noncompliance with stated policies, such as not wearing PPE, failure to adhere to all processing protocols, and any other instances of noncompliance with policies and procedures. These issues relate to employee and patient safety and must be reported. And there have been several studies that have been published that showed a high percentage, and I don't want to say because I don't remember off the top of my head, but a high percentage of people who were reprocessing flexible endoscopes said that they could not follow all of the steps in the reprocessing because they were not given sufficient time. They were told they had to turn that scope around in a certain amount of time. And we cannot do that. We cannot do that.
Reporting. Each facility has a corporate compliance policy, and some facilities have a hotline that can be used to anonymously report any compliance issues. So if you feel that, you have something that you want to report, you can use your employee hotline. And as I said, you don't have to give your name, and then you can go back and not have to worry about it. And they will follow up on it. Remember, ethics means doing the right thing. When processing endoscopes, attention to detail and the ability to do the right thing is required all the time, not just when we have the time. And this means taking a long, hard look at our practices. These are the important things. Is your staff thoroughly trained with competencies verified initially and annually? Again, these are things I ask for in litigation. Who performs the competencies? Is it someone who's ever processed an endoscope? I was in a very prestigious facility that was doing Fortune 500 physicals for corporate people, and they did colonoscopies on all of the employees who were going to be potentially hired by these big companies. And they called me and they said, can you come in and do competencies on our staff? And I said, sure. I said, what's the problem? And they said, well, we had the Joint Commission in here, but they would not accept the competencies that we had done. I said, why? And they said, well, the endoscopist did them. And they went to speak to the endoscopist, and they asked him if he ever cleaned or disinfected the scope. And he said, no, but he used them all the time. And they said, we will not accept that. So they want to make sure that whoever is performing the competencies is someone who has been working with endoscopes, who knows them thoroughly, and can truly assess the competency of the individuals who are processing the scopes. Third, do you have a sufficient inventory of scopes and processing equipment and staff to permit processing in full compliance with the IFUs? Today we have to initiate the cleaning within 1 hour of the pre-cleaning and the disinfection within 1 hour of the cleaning. We have so many more steps that have been added to our processing, and we cannot skip one step. And when we do, it can be very detrimental to the patient. And it puts the employees in a very difficult position because they know they should be doing something different, but they're being told to do something else. And that's really a very serious ethical issue. Is there a quality monitoring system in effect to monitor compliance with the instructions for use and verify the cleaning of the scopes before high-level disinfection or sterilization? Again, when I ask for policies, I very rarely will see anything mentioned about enhanced inspection of the scope, about verification of the cleaning. I'm still seeing scopes that aren't tagged before they're put into the storage cabinet. So we have to make sure, even if you have up-to-date policies and procedures, which should be based on SG&A, HICPAC, CDC, and AMI standards, then you have to have a monitoring system to make sure people are complying with them. This is the number one complaint I get from the Joint Commission all the time. Oh, they had lovely policies, but nobody knows what's in them, or nobody's following them. And when you don't follow a policy, that can get you in very, very deep trouble legally, and you don't want to have that issue. Now, there's an organization called the Emergency Care Research Institute. You might have heard of it. It's called ECRI. And every year, they publish a report on infection risk in hospital settings. For the year 2020, they report infection risk from sterile processing errors in medical and dental offices, and that includes endoscopy, made number 3 on the list. For the past 8 years, errors in processing scopes and other instruments and devices have made the top 10. As a matter of fact, scopes and instruments were in the top 10 for about 3 or 4 years in a row. So the issue does not appear to be getting better. The only reason why scopes and instruments were number 3 on the list, because last year with COVID, they had some COVID issues that were identified as greater infection risk. Dealing with ethical issues. You cannot rationalize out of an ethical dilemma. Well, I just didn't have the time, so I just had to do it. It still doesn't mean it's right. And we have to understand that the solutions are not always black or white. Sometimes there's a gray area. What is the risk versus the benefit if we do this? Your action must be an informed decision based upon sound professional skills and knowledge. And the fear of losing your job or educating others should not dictate or influence your stand on this ethical dilemma. We have to do the right thing all the time. As we drift along with the changes in healthcare, we need to reaffirm our personal and professional ethics. Remember, we selected to work in healthcare, and our patients are counting on us. When we do not do our job, it not only affects the patient, it affects their family, and it eventually can affect your facility. And one of the worst ways to get publicity for your facility is to have an event that did not do well for the patient. And it's very difficult to erase that because people remember those things. They don't read so much about what's going on with everything you do right, but do something wrong and it's always there. We do the right thing because it's what we're trained to do and what we're required to do. And we have to be able to do that every day. And these are the references that I used for the presentation. Thank you. I hope you found this helpful to you. And I think we're going to have some questions now.
All right, Nancy, thank you so much for this information, talking all about the ethical issues in endoscopy processing. And I think these issues can be spread across sterile processing, even outside of endoscopy processing. Hi, everyone. I'm Lindsay Brown from the Beyond Clean team. I'm joining Brett and Nancy for a question and answer session today. Nancy, I wanted to just start off, before we start fielding audience questions, all of this conversation about ethical issues, moral issues, things like that related to such a high stakes job. I want to ask what your opinion is on this specific question. If I haven't, as an endoscope reprocessor, and I have the CBSPD certification, the CFER certification, I reprocess endoscopes. If I haven't been given the correct tools or the correct training to do my job, is it really my fault if someone gets hurt? What are your thoughts on that?
Well, there's two areas of responsibility. The professional associations do say that the facility needs to provide training and continuing education because, remember, the people who are doing the endoscopes, for the most part, I know in some facilities some nurses do it, some technician, surgical techs do it, but for the most part, there's an endoscope technician. And they are some of the lowest paid people in healthcare, just like in sterile processing. So many of them don't have the money, nor is there money in a budget for continuing education. So it is a manager's responsibility to provide education for them. And there are many opportunities for education. In a court of law, when I ask for education records, if I don't see anything that was given to the employees in terms of specific to endoscope processing, I put that burden on the facility because they ultimately are responsible to ensure that their employees know the current standards and practices because they're supposed to be following them. The people who are doing the processing might be certified, but we have to understand the certification is minimum competency, and then we build on that. So we build on that because of all the changes that are coming down the pipe, with drying scopes and cleaning and microbiological testing. All of those things people need to know about. And they're not going to know about it unless someone gives them that information. And it is the responsibility of the facility. So if someone did not process the scope correctly, technically the facility is responsible because they're supposed to have policies and procedures that are referenced to the most current standards. I hold the manager responsible, and this is in a court of law. That is their responsibility. If the employee doesn't comply with the policies and procedures to ensure competent practice, that's a different issue. But if you don't even have the policies or policies that are not current and up to date, then we can't blame the employee for that.
Yeah, something that brings me back to, and I've linked both of your podcast episodes, or the first two podcasts. I think you've done 3 interviews with the Beyond Clean team on our podcast, but the first 2 are linked in the resources tool on the screen. And in one of the episodes, during your interview, you said, if the manager is not providing continuing education in the department, then that manager should be ashamed of themselves. And just point blank, you just put it out there. And you went on to talk about the fact that many technicians, and you've already referenced the low pay, they either can't go out and find education for themselves because either the hospital won't pay for it, or they can't get the time off, or can't afford to get the time off to seek out educational opportunities. What tools can you give, or what motivation, maybe I should say it that way, what motivation can you give leaders about that, the importance of offering continuing education opportunities right to the staff members in your department?
Well, first of all, it benefits everyone. It benefits the patient. It benefits the employee, because nobody wants to come into work and then be told they did something wrong when they didn't even know they were doing something wrong. And thirdly, it avoids litigation, because if you're following the standards and doing what you're supposed to do, you're not going to run into problems. You run into problems, and I see this 100% of the time. The policies were very obscure, they were not specific, and they were not current, and they were not referenced to the relevant organizations that oversee endoscopy. So I put the burden on the manager and say, look, this is your responsibility. It's not just the nursing. You know, you'll see plenty of time is given for nursing procedures, and I could say that as a nurse. It's important for the nurses as well. But you can't find a more at-risk device than a flexible endoscope. And we have to make sure, I don't know if you're all aware that AMI, the Association for the Advancement of Medical Instrumentation, is updating the 2015 endoscope document. I co-chaired that with Marianne Drosnoff, and we knew as soon as it was published that we were going to have to continue to update it. But we wanted to have a national standard, because prior to that, there was no national standard for endoscopes. So who was following SGNA? Who was following AORN? Who was following HIPPAC? And even Joint Commission said at a national conference, people, get your act together. Because we go in and you have 2 departments that might be processing scopes, and they're following different standards. And unfortunately, sometimes these standards are not saying the same thing. So it's really important that they meet the needs of all of their employees, including the endoscope reprocessors. Now, there are many programs that are free. I get invitations all the time. The manager can look up online. I'm not going to say company names, but there's many, many companies that have in-services specifically on endoscope reprocessing, and take advantage of it. And, find out what they need to know to keep them safe and keep their processing safe. But it is the manager's responsibility, and I think the employees have to really make that known, that I don't feel that I am properly trained. I don't feel comfortable doing this. I need more training. I always tell people that if you don't feel comfortable doing something, if you don't feel that you were trained enough, you have to let someone know. And I'll give you a perfect example. I was in a facility about 4 years ago, and I went into the endoscopy department, and then they told me to go to the operating room, and I was meeting with the OR staff, and they said, we have to process the endoscopes when endoscopy is closed. I said, okay, what's wrong with that? They said, well, we don't know how. I said, what do you mean you don't know how? Well, nobody ever showed us. They just had some pictures on the wall. And, we might do it once every 3 or 4 months, and we don't feel comfortable doing it. I said, well, then shame on you. I said, that would be like me getting into a semi-truck and trying to drive it when I have no idea what I'm doing. I said, this is very, very serious. You have got to bring this to the attention of risk management and infection prevention. There's nothing wrong with your being assigned to do this, but you have to be trained with competencies verified. And in a situation like that, I usually recommend you take maybe 2 or 3 people who are going to be the quote-unquote experts, and so that they're doing it repeatedly so they become more comfortable doing it.
Yeah, and Nancy, to your point, I think it's also about standardization across all departments, right? Because it's not just one department that's utilizing GI or, like GI or, they're not the only ones in the hospital that are utilizing scopes. And, there could be different reprocessing stations or, areas around the hospital. So they all need to be in, on the same page as far as following the standard practices and procedures. And if, like you said, if they don't have that training, and maybe one department does, but if they don't have it across all departments, it's really critical that they all have the same standard of training and education.
Agree. I mean, I know in many facilities, bronchoscopes are often processed in the respiratory therapy department, and they're kind of, forgotten. And in a lot of instances, we have some questions. Do we have time to do them?
Oh, yeah, absolutely. Yep, we've got plenty of time to get through them. So, and actually, Brett, that brings me back to Sunil's presentation, the previous presentation to this one, about his emphasis on documentation and how that can help the overall process, the overall workflow, and making sure that that consistency and that high level of standard is there. I love the interconnectedness of these sessions. And for those of you who are managers, I know there are a couple managers who have submitted some questions. If you're looking for in-services about endoscopes, you've got 7 of them right here from today that you can use that are CE approved. So, offer CEs, and feel free to take advantage of these sessions because they'll also be available on demand at any time for you and your staff to access. Nancy, one of the questions that came through is, how do managers introduce the accountability technicians have without introducing the fear of performing the reprocessing of flexible endoscopes? What would be your recommendation? Because obviously we hear all the time, nobody's doing it right. Nobody's doing it right. And obviously the risks are enormous. So where is that balance?
I don't think we take enough time to educate the endoscopy processing technicians the importance of their job. And sometimes I hear from them, well, how could it be important when I'm being paid $9 an hour? And there's some truth to that. But, I start with, this is what your job is. This is the definition of an endoscopy processor. And these are your responsibilities. If you do not do this, this is what can happen, because many of them don't even understand that. We talk about scopes that are not properly cleaned. Well, what can happen? Well, we could have bioburden, we could have blood, we could have tissue that is still in the scope that we transfer to the next patient. That patient can get an infection, and that patient can not only get the infection, but could be subjected to death depending on their immune response to that infection. I don't think and that's not a scare tactic. They need to know that that is part of the pros and cons of their job. Not everyone, in my opinion, is cut out to work in processing, whether it's in a sterilization in a hospital or an endoscopy center. You really have to be a patient advocate. You have to be someone that says, no, it's got to be done this way. I don't care if someone is standing there stomping their feet saying the doctor's waiting. It has to be done this way, and it's going to be done that way. But they don't really understand the importance of their job. Very often I have seen where technicians are almost treated like robots. Do this, do that, do this, do that. But they don't understand the why. When people understand the why you have to do it that way, it's not me, the manager, telling them you have to do it this way. It's the standard that's telling you have to do it that way. And we're very fortunate in that respect that we're so highly regulated or guided by all these standards. And that's why I said it's so important to have all of your policies referenced to national standards. So they can't say, well, I think you're just being, hypercritical and you want us to do all these things. Why do we have to do them? Because this is the document that says that we have to. And if we don't, we could, do harm to a patient. And it really is a conversation that everyone needs to have, because I don't think a lot of people in sterile processing or endoscope processing, because endoscopes now, as someone just said, can be done in sterile processing. They could be done in the OR. They could be done in respiratory therapy. They could be run in endoscopy. There's multiple departments that are doing it, and everyone needs to realize how important it is.
You know, something that comes to mind right away when you're talking about endoscope technicians, endoscope reprocessors needing to understand the why behind following all the steps. That why also needs to be understood from the requesting department, from the surgeon, the physician, from the nursing team. I think that the understanding of why those steps need to be followed and the time commitment required for following those steps needs to be understood across the board. I know a lot of the focus, like I said, is placed on making sure that the person doing the reprocessing understands the why, but they know why. They just have all of these other issues like time constraints and pressure to turn things over quickly, and people telling them to skip some steps because there are patients that need a procedure done. So do you think, and this is just my opinion, I think the why needs to be better understood from the requesting side than the reprocessing side. And maybe that's just a balance that needs to be created. Obviously it goes both ways, but what are your thoughts on that?
No, you're absolutely correct. I haven't run into that in endoscopy, but I did run into it when I was working at a trauma center, and I went in because they were having major issues, and the first thing I did was meet with the trauma team. And all I heard was, why does it take, 5, 6, 7 hours to get a trauma tray back from your department, blah, blah, blah. And I looked at them and I said, do you have any idea what it takes to process the tray? Well, no, but the nurses tell us it's 2 hours. I said, well, how do they know? Did they ever process the tray? I said, there is a process that we have to follow. If we do not comply with an instruction for use every single step, then we, the facility, are liable. And you, as the endoscopist, or in this case, trauma surgeon, could also be responsible. I said, true, nothing should be brought into a treatment room unless it's safe for the patient. But the physician doesn't know that. They're assuming whatever is brought in is safe. And because very often the staff does not know, it's like walking a mile in someone else's shoes. The staff needs to know what the processing is, what it takes. And I've said many times, I think it would be great if some of the endoscopy people would go in and look at what it takes to process the scope. They just have to look at one. I did it one time when I was in a hospital setting, and after a half hour, they said, I'm out of here. I just never seen anything like it. I had no idea all of this was involved. Yeah, the days when we used to do things, and I will say it, we did things very differently, but we didn't know any better. We know better now. We have standards now. We have to follow them. And everyone needs to know. If you need to know that this particular scope is going to take 75 minutes to turn it around, then don't promise it to the endoscopist that they're going to have it in 15 minutes. Because what happens is now the reprocessing technician is being forced to push that through, and steps are going to be skipped. And where is it going to be skipped? Probably in the cleaning, because once you put it in an AER, you can't really shortcut that cycle. So this is something that we have to educate even the endoscopists. I do a lot of work with endoscopy centers that are owned by endoscopists, and I have to educate them very often because they'll say, I don't understand this. Why do you say we need another processor? And I'll give them the reasons. And they get it. When you talk about liability, when you talk about patient safety, they do get it.
A couple of questions that have come through are themed, actually. They are definitely related to one another. The first one says, what do you do when your coworker doesn't take what they do seriously, like documentation or cleaning? You said something and nothing's changing. And the second question is basically the same thing, but related to performing the competencies in the training, where they're the ones skipping steps. They've brought it to managers and it's been brushed off. That's quite an ethical dilemma when you know that you can't control the people around you. What advice, what insight do you have for folks who are experiencing that?
Well, first of all, with documentation, again, in a court of law, if it wasn't documented, it didn't happen. So people need to understand how serious documentation is. As a matter of fact, I developed the whole program on documentation, your liability with improper documentation, because I'm seeing such a poor result when I ask for documentation. In one case, they never documented that the scope was leak tested. And, we do it. Prove it. They had no way to prove it. See, we all assume that everybody knows what we do, but in a court of law, if you didn't document it, it didn't happen. Now, because that documentation is so important, I always advise people that every day you come in, someone in a management or leadership position should be responsible to review all the documentation from the previous day. Were all the printouts there? All the printouts signed? Were all the parameters met? Was the leak test documented? All the things that your policies say you're supposed to do, were they documented? And if not, it's so much easier to make the correction within 24 hours, because, when people see, oh, we have Joint Commission coming in, and they start going through records and, oh, well, we don't have a result here, so they just write it in. That's falsification of documentation. How do you know that result was positive or negative? So you have to be very, very careful with that. Regarding having someone doing the competencies who's not doing it correct, that is the worst type of liability you could have. And it also discourages the other employees in the area. Now, I don't know if this is in a hospital setting. It's a little bit different in a hospital setting than it is in a ambulatory surgery setting. In a hospital setting, there's usually infection prevention and risk management on site. Or you could even go to HR and tell them, anonymously that these are your concerns. This cannot be left undone. Because if you have someone who's not doing all the steps and yet they're being charged with doing the competencies and training, something is very, very wrong there. And it's going to lead to a problem if they don't fix that.
So with all of these things in mind, how is a manager to identify and hire people with good reprocessing ethics? Are there certain qualities, certain characteristics that managers can look for, or can those things be trained once people are hired?
I always look for, it's very difficult when you're interviewing people. I guess I have like a fifth sense. Usually within 5 minutes, I can size up a candidate if they're going to be a good fit or not, because I'm not as concerned with their training and education, because quite frankly, I've had people who came to me who were certified and were still doing things wrong because they got into some bad habits wherever they worked, or they were not following the latest standards and guidelines. I'm more concerned with people who understand the importance of the work, that understand that, in this department, we have to do things right every single day. And every time we process a device, we have to look at it and say, would I want this used on me or a member of my family? And if they don't have any hesitation, then it's probably okay. And if they hesitate for even a minute, then they shouldn't be working there. But it's very difficult to instill pride into someone. Either they have it or they don't. And that's why we have the 3-month probationary period. Because I said the training is one thing, but the ability to do things the way they're supposed to be done, be a team member, and doing the right thing, those are things that you cannot always iron out in an interview. And you certainly don't want anyone in the department who's not going to be a team member, because you have to work together. You have your peaks, you have your valleys, and you can't have one person who's not on the team, so to speak. So to me, if I said training, I will do the training. But when it comes to the other things, you have to pay a lot of attention during that 3-month probationary period and see if they're going to be a good fit.
Yeah, I completely agree, Nancy. I think, I've been in departments, like you said, where people, you have new employees that maybe aren't fully trained, but they have a passion and an energy, and just they really understand the real importance of patient safety and what their job entails and what they bring to the table. I mean, they're the beginning phase and the most important phase. And, you know, I've seen some nasty infections, and it's awful. And so, yeah, I think identifying those people that just have that true passion.
Yeah, and also, you know, when people are coming into work, they have to understand that the way they do things, and I'm not talking about following procedure, may be different than someone else. I had an individual who was an absolute wonderful worker. Her job every day was perfection, but she was slow. And everyone would beat up on her. So, yeah, I could do 3 scopes in time it takes they do 1. Yeah, but her 1 was perfect. The others, not all the time. So we have to understand that not everyone learns at the same rate or works at the same rate. And if they're getting the job done and at least meeting the minimum amount of productivity that we need, that we shouldn't be, you know, turning our nose up at these people.
Exactly. I think slow and perfect is better than fast and imperfect, because then you're having to go back and ultimately it affects the patient.
Oh, sure. Absolutely.
Yeah, I've got a question I want to get out to you from our audience. How do you cover yourself if your coworker is skipping a step?
Whoa. Well, I would give the person a pass and speak to them one-on-one and say, look, Nancy, I noticed that you're not doing this step. It's in the instruction for use. We have to follow all the steps. I don't know if you realized it was there, but, you know, just keep it in mind. You have to follow all the steps. And then I would keep an eye on the person. And if I saw it happen again, then I would go to management, because obviously the person didn't take it seriously.
Great question and great answer.
Mm-hmm. Yeah, and that leads right into the next question. Should you talk to your coworker first? And so that's great advice. This next question is related as well. What do you do when the person training you is telling you to do something that you've discovered is not in the instructions for use? What's the pathway of communication for that instance in your recommendation?
No, that's just as bad as not following all the steps in the IFU. Here is the fact in a court of law. The FDA gives the responsibility to the device manufacturer to validate the processes needed to safely reprocess their, in this case, endoscopes. They've done the testing, they submitted the data, and the FDA said fine. The other side of the coin is users, and that's us, must replicate those instructions exactly as presented. We're not allowed to add alcohol unless it's in the IFU. We're not allowed to use peroxide unless it's in the IFU. We can't change the chemical unless it's in the IFU. When we do, we, meaning us and our facility, assume full liability for the safety and efficacy of the device, and I can't say it any stronger than that. There is no excuse. That's telling, in a court of law, they're saying, well, I knew more than the manufacturer. I thought if this was good, this is better. No, we're not allowed to do that. Not allowed
I have a question. You know, so, you know, a lot of IFUs are out there very, you know, very confusing, very long. And I have seen IFUs, especially on the chemical side, where they are giving the wrong instructions. What is your opinion on that? Is that an immediate call to the manufacturer? How do you steer a sterile processing technician through that challenge?
You mean the instruction for use of the chemical is incorrect?
Well, I've seen it, or it's not summarized very well, or it's telling you to use the incorrect chemical. I'm not going to call out anybody on this, but I've seen it. And so that would be something, you know, the question would be how you would steer a technician through that question and through that confusion if they are following an IFU that is actually telling them to do the wrong thing.
Well, here again, liability. We have the FDA puts the burden on the facility to report first to the manufacturer, and if they don't correct it, then to the FDA. And I actually testified in a lawsuit where they were having trouble cleaning a particular scope. They never reported it to the FDA. They said they told the sales rep, but it wasn't documented. So they decided on their own to use a toothpicks, to use a water pick. It was crazy, the stuff they were doing. Absolutely nothing in the IFU that they should be doing any of that. And they were in non-compliance with an FDA regulation. If you have a problem with any IFU, either you can't comply with it or it's unclear, you report it. You can go on the FDA website, the MedWatch 3500 form, and document it there, but that's going directly to the FDA. I usually call the company first and give them a chance to fix it, but I'll give them like 24 hours. I had an example about a month ago. I had a facility that was processing eye instruments, and they had an IFU that only gave unwrapped instructions. I said, wait a minute, we don't even do unwrapped sterilization anymore. So I called the company and I spoke to their product manager and I said, here's the problem. And they said, we'll get back to you within 24 hours. They sent me a new IFU.
Oh, nice.
So, they're supposed to respond. And if they don't, I give them a deadline. I said, I need this in 24 hours. I need this in 48 hours. If I don't have it, and I do let them know, if I don't hear from you, if you can't resolve this, I will have to report this to the FDA. That makes them really work hard.
Thank you.
The question, when you're looking at let's take a 30,000 foot view. When you're looking at the whole process from development of an endoscope, from the engineering and design and manufacturing of the endoscope, going through the testing to create the IFU, the validation testing, these are the steps that need to happen in order for someone to render this device safe. FDA says, yes, we agree. Is there any fault that could potentially be placed on the FDA's side when it comes to ethical issues related to these super, super complex devices?
Well, they're trying. I mean, they have already told the device manufacturers that they would like them to come up with not only endoscopes, but there's many other things that people have to reprocess that are very difficult to clean. For example, your robotic instruments. And when you think of Fraser sections, and some of these things are very small lumens that we don't even have brushes to get inside. So they want them, A, to make it easier to clean unless there's no other way to design that device, and B, to simplify the IFUs. Now, there is a document that Amy is working on, manufacturer's instructions for use. They're trying to harmonize with Europe, where the instruments are going to be categorized by the level of difficulty for cleaning. So category 1 would be the easiest to clean, say like a probe, a knife handle, things like that. And what they're hoping is that every instrument manufacturer will have the same IFU. So if I have knife handles from 6 different manufacturers, I don't need to have 6 IFUs. It's a work in progress. There's a lot of work that has to be done yet. But there is some light at the end of the tunnel.
All right. Well, I think we're getting close to time here. Linz, do you think we have time for one more?
Let's do one more question. So many great questions have come through. Thank you so much, everyone who's tuning in. And clearly there are some communication opportunities out there in the field. This question says, what happens when you know the scope passed a leak test, when you processed it, but it was damaged through the procedure and they don't have a way of knowing it? Like, it passed the leak test. You as the reprocessing technician know that it wasn't your fault, right? Because you followed your process, you documented it, but there's no way to document that something happened in the procedure room. How does someone navigate a situation like that?
Well, first of all, we have to make sure that the leak tester is functioning properly, and this has come to light within the past year and a half or so. There are now pieces of equipment to verify that your leak tester is working correctly. So you could be using this leak tester and it's telling you the scope is okay, and it may not be. So now you have an opportunity to unequivocally state the leak tester was working. It told me the scope passed. This scope was fine when I sent it to you. You have that documentation. And with that documentation, if there was a complaint that the scope, got damaged, not here. It had to happen in the operating room. And I actually had this happen a number of years ago. We had a brand new device that was brought in. It was a peritoneal scope, very, very expensive. And we processed it, sent it up to endoscopy. They were using it there, and comes back, and we reprocessed it, sent it back, and they said it's damaged. I said, wait a minute. We followed all the instructions. No, it's damaged. Okay, so we sent it out for repair, very expensive, comes back, same thing happens. It's damaged. So now I followed the scope up to the room. And with this particular scope, in the instructions, it was very clear that when you remove the scope, and it was a very, very delicate scope, very thin, and it was metal, but when it said in the instructions, when it was removed from the case, to don sterile gloves and support the actual telescope, because if you didn't, the lens could fracture. And so I'm watching the resident take it out, just rips it out and puts it on the table. And I said, hook it up to the machine. And they hooked it up, and of course it was broken again. I said, there's your problem. You're not following the instructions. So we have to follow instructions in processing, but they also have to follow them in use as well. And they have to make sure that people are following the instructions for inspection. Are they inspecting these before they use them? That's really important.
Very important, for sure. Well, thank you both for hopping in. Linz, I know you've had a busy day, and thanks for joining us. Yeah. Nancy, we can't thank you enough for joining us as well. And actually, we're looking forward to you hopping on the next panel. So we'll have some more great discussions upcoming. So appreciate you joining us all day, or everybody out there joining us. It's been a great day of learning and new ways to think about the world of endoscopy and improving patient care, and just overall making sure that we're doing the right thing for our patients. So thank you, everybody. We've got one more. If you can stick with us, it's going to be a good one. We've got a great panel of speakers. And so we will see you on the next round, and grab a quick snack, drink of water. We'll see you shortly.
Thanks, everybody.
Thank you.